moving in and out, so this will be a good time to take questions, and then we'll get back to the slides. So, which I might actually show you guys this time. So, you know, just for fun, we'll try that one. Okay, so I have a question here. Can medication like gabapentin, I assume that's what you're talking about, cause brain trauma when taken off of a drug abruptly, specifically in a person with cerebral palsy? Well, I'm not a physician or a pharmacist, so there's a limit to what I can be qualified to answer for that, but I will talk a little bit. I think in this case, you were talking about trauma in the sense of the most basic sense of the meaning of that word, which is injury, right? So can there be an injury to the brain if there, any substance is abruptly stopped and not tapered or given a chance to adjust? And my guess would be sure, because I think that can happen in a lot of different cases. What the result would be is probably not trauma in the sense that we're talking about it here, like another way to talk about the experiential trauma that people have experienced is like a learned fear reaction. Okay. This could cause all kinds of brain damage. I don't know what it would be potentially. Again, I can't say that specifically about this medication. I can say if people are on medication for a long time and they're taken off of it abruptly, all kinds of bad things can happen. So the answer is yes, although probably not in the way that you're thinking of it based on. And it's a good, whatever the case is there with that situation. And as I said, I can't speak to that. But I will say that it's another argument for making sure that nurses and nurse practitioners and physicians and psychiatrists and pharmacists have training and experience in working with people with developmental disabilities and all other kinds of disabilities as well, right? So that things like medication are very carefully managed. Some people have a lot of different neurological things going on. Cerebral palsy is, as you guys all know, already brain trauma. It's an insult to the brain, usually at or around birth. So we really, really need to be advocating for getting our people working with medical professionals who have training and experience in these complex presentations. So thank you so much for that question. I hope that got towards what you were thinking about. Okay, we are going to pick up now with the second half of our time together. And we will be taking one more break about halfway through, although it will be shorter. So I'm going to go ahead and bring those slides up one more time. Actually, let me do that one. I think that one will work. Yeah, okay. And we talked as we left about what is going on in the brain when we are presented with what we experience as a threat, and that all of us are built with a system in which we might go into that hyperarousal, fight, flight, freeze, fawn, or hypoarousal, the disconnection and checking out. And either one of those things is much, much faster than we can think about it and not a decision we make or within our control. So looks like we've got Kevin joining us. Are you stopping in to make a comment, Kevin? Nope. Okay. So these slides, I'm not going to spend a lot of time on, but essentially it describes three different zones of our brain, kind of the way we've already been talking about it. So the engagement zone is like that white window of tolerance, that area in the middle where our environment is sufficiently safe and welcoming and we feel okay, and we can interact with the world to whatever extent we normally do that, right? So for example, if you work with folks who are on the autism spectrum, they may engage with the world differently than other folks do, and that's their normal. So whatever my normal is. And so engagement just means that I can allow that give and take with other human beings in my environment. Don't worry about the evolutionary stuff. That's part of a larger training. Hyperarousal is when the alarm system in the house has been set off. Right? So there's a desire for action to get safe. So it's this very activated state. And then hypoarousal is when I'm shut down and there's no power. So I always like these slides. This is from a psychologist I got to see present from California. He said, being in hyperarousal is like, the tiger's chasing me. And hypoarousal is the tiger lives in my house. How would you conduct yourself if there were a tiger in your house all the time? You'd probably be very quiet and very small, and your life would get very, very, very limited in order to not get the attention of the tiger. So some of the folks that you work with who present or maybe described by other people as, oh, Laura's so sweet, she's never a problem, she's never upset. Maybe that's the case. But if I seem like super quiet and withdrawn and compliant all the time, what you may see is someone who lives as if there's a tiger in their house all the time. So whenever I do consultations, when we work in like different states or different providers, whatever, sometimes we'll talk about individuals that folks are struggling with and trying to bring a trauma perspective to that. And usually people talk about individuals who spend a lot of time in that hyper-aroused state, right? They're violent, they're throwing punches, they're self-harmful, they take off running out the door. They drive everybody crazy, and there are, all these staffings and plans to try to deal with that. And that's obviously really important. But I will say that sometimes I worry more about the people who live with a tiger, the people who are very compliant, who are very quiet, who are very withdrawn. Sometimes I think the benefit of freaking out and being a pain for everyone around you is that it draws attention to what's going on with you and potentially gets you some help with it. When someone spends a lot of time in that collapsed dissociated state, it's easy to miss it, especially if you've also got people doing all the fireworks, right? That kind of takes up all of the attention, and it's easy for some of these other folks to sort of slip through the cracks because of that. So I really want to draw your attention, not just to the big, obvious hyper arousal states of some of the folks you work with, but also tuning in and becoming sensitive to when people are in those hypo aroused, numb, checked out states. Okay, so here's yet another way of looking at this. Excuse me one sec. So this is adapted from a wonderful therapist's work named Deb Dana. And when I do longer trauma trainings, I talk about vagal theory and polyvagal theory, which is a really major direction that we're moving in for treatment of trauma. It refers to the vagus nerve, which runs from your brain all the way down through the center of your body. And it's sort of the brakes of your nervous system. So often what's happened when someone has been habitually in that alarm state is the brakes aren't working very well, or they're on too hard. So it's really working with the nervous system in the body, which is where a lot of trauma treatment is going. Anyway, this is just another way of sort of outlining what it means when someone is in that engagement zone. Don't worry about ventral vagal. That's from vagal theory. They feel relatively safe in their body and they can interact with the world. Or they're in that hyperarousal state. This should say flight, fight, freeze, fawn. They're mobilized, they're activated to get safe, or they're shut down and all the power has been cut and they try to experience safety through stillness. So as I said before we took our lunch break, people usually want to teach other people from the top down. So if something is going on with you, you're acting in a way that's harmful or disruptive, or something's going on with you, I kind of want to try to talk to you and get you to talk to me and engage your thoughts and use that part of your brain, which is understandable. But if someone is in their blue zone or in their red zone, that part of their brain is relatively offline. They often can't do much or even any of what it is we're asking of them. So that means we have to do something differently. And that's why when we talked about safe, connected, and in control, what we're saying is we're going to go right in to try to address that alarm system in the brain and shut it off, right? If your kitchen smoke detector is going off, the first thing you do is you shut it off and you get the burned toast smoke out of the kitchen. So that's the first thing, safe. The most powerful, quickest way to do that is through connection, helping that person to feel validated, heard, recognized, connected to you, You're there to help them in whatever way they receive that. So again, I might be somebody who really likes a hug and closeness, and Troy might be somebody that needs more space and no eye contact. So that formula is where your relationship and your knowing that person comes in, but it's the same brain process that we're engaging. We're releasing dopamine and serotonin into the brain. And there are other ways to do that as well. So for example, when I worked for the Department of Mental Health, a lot of the forensic hospital units, the psych units, were working on creating sensory carts. A lot of you have this for other reasons, for folks on the autism spectrum who have sensory issues, where there's, things that feel fluffy and warm, or weighted vests, or, a nice warm cup of tea or candy that tastes good, or whatever it is. So all of those things can support that. And I have found that there have been some agencies that we've worked with who've incorporated trauma responsive care and use their sensory room or sensory carts or whatever. And it works, right? The reason it works is that those positive associated sensations, warm, snuggly, pressure, whatever it is, signals to the amygdala, everything's safe, it's okay, you can turn off the alarm now. So the brain stops pumping out norepinephrine and cortisol, and it starts releasing dopamine and serotonin. The most powerful way to do that is through the relationship or the interaction with another caring, warm human being. So all of that other stuff is wonderful, but kind of secondary to the human connection, okay? And then we go through that to in control. I now can think, to whatever my ability typically is, about my choices. Do I want the consequence of punching this person in the face? Right? Or I don't actually like the scars after I cut myself. I think I'm going to stop doing that right now and put the razor blade down, whatever it is, right? So safe, connected, in control, based on brain science, not just because it sounds nice. So how do we apply that? Okay, well, as I've already said, it is relationally based. So it fits in well with lots of other things that you guys might be doing with your individuals. For folks who work with children, this works beautifully with if you're doing play therapy or floor-based interventions or home-based stuff, great. I believe it works well with gentle teaching, person-centered planning, any kind of like empowerment stuff that you guys are doing with your individuals. And I also think it can weave in well with things that have a different focus. So a lot of times people will ask about trauma responsive care and ABA. I think they work very nicely together. Just because you are focusing on behavior with ABA doesn't mean that you're not also ideally creating a supportive, caring relationship in those interactions, right? So it's relationally based and it fits in with whatever else you guys are doing. Universally applied. We're going to talk about this. So remember when I said early on that if you look at the rates of big T trauma, capital T traumas, that we know that people who have developmental disabilities, or sometimes we talk about dual diagnosis, whatever it is, they are more vulnerable to those big T traumas happening to them because they're more likely to be victimized. Right? We kind of know that, right? So sexual assault, sexual exploitation, physical abuse, emotional abuse, verbal aggression, all of that stuff, they have higher rates. And when we add the little t part, so this is big T, when we add little t and try to put them together, some estimates are higher than 90%, which means basically everyone. So we say that this has to be a universal precaution. And we deliberately chose that to go along with your first aid training. Everybody in the room has first aid training. You guys have to get trained, every 2 years, every 3 years, something like that. Well, how do universal precautions work? We all got a booster course in this with the pandemic, right? With masking. The way it works is, when you take your first aid class, what you're taught is that if you're my staff person and I get, let's say, a cut, okay, and I'm bleeding, you don't just grab a Kleenex out of your pocket and clean it up. You stop and you put gloves on, right? Why? Because I might have something in my blood. I could have hepatitis or HIV or whatever. And if you have a teeny little abrasion or break in your skin, it could be transmitted to you. And now you have that disease. We all know this, right? Now, The reason that you do this every time is because you can't know if I have that illness just by guessing, right? I could have one of those bloodborne diseases and look fine, right? I may not know I have it. It's also not reasonable to go, okay, Laura, well, I'm going to take a sample of your blood and I'm going to run and have it tested. And then if you're okay, you can have that Dora the Explorer Band-Aid. That's crazy, right? I will have bled out long before that happens. So what do? You treat me as if I'm sick. Now, you don't start giving me a bunch of antivirals. That would be invasive and dangerous. But you just say, I'm going to treat you as if you have something I could catch. And so I will put on gloves before I come in contact with your blood. When I clean up afterwards, I will use a bleach solution or something. So what does it cost you if you treat me as if I'm sick and it turns out not to be true? I'm not sick. You didn't actually need to do that stuff. What did it cost you? Nothing. Fractions of a penny for latex gloves and a little bit of bleach and some water. Nothing, right? What does it cost you if you guess the other way and you're wrong? It's catastrophic, potentially fatal, right? So the smart bet is I will treat everyone as if they are sick, and if I'm wrong, it's no big deal. It is so elegant and simple. It's easy to not see how brilliant it really is. It really, really works. When we use universal precautions, it cuts way, 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 way down on the transmission of those infections, right? Okay, you already know how to do this. So we say that TRC is a universal precaution because any individual you come in contact with, more than 90% of them. So imagine your room that you're in right now. Let's say there are 100 people in the room, and I think it's roughly how many folks we have today. So imagine that all but 10 of you have had some level of traumatic stress, and we may or may not know about it, right? That's the other issue. Just like I may not know that I'm sick. If nobody tested me and I don't have any symptoms, I may not know. We know that people with developmental disabilities are at greater risk for having traumas occur to them, and they tend to be underreported. There are a number of reasons for that, most of which you're very familiar with. Number one, it's easy to intimidate or threaten somebody and tell them, you're going to be in trouble if you tell, and they believe it, so they don't tell. Or they have limited verbal ability, or they have no language and they can't tell anyone. Or maybe someone did know at some point, but remember what we said about trauma is worse neurologically early in life. The younger you are, the more damaging it potentially is. Okay, well, think about some of the folks you work with. I may have some of you guys who work with younger people or kids or teenagers, but I know that some of you work with people who are in their 50s, 60s, 70s, maybe 80s. We are getting better and better at medically treating people. And so folks with developmental disabilities live longer and longer lives, which is great. The downside, if there is a downside, it is that we are farther and farther away from knowing anything about those vulnerable years of their lives. Some of your folks, they could have been raised by wolves. Nobody knows, right? And so because of those two things, trauma is underreported, underbelieved when someone does report it. You didn't understand what they meant, or that staff person's never had a problem with anyone else. You get what I'm saying. Or it happened so long ago, there's no one who knows about it anymore. Either way, however that happens, there are big T traumas that you will miss. So whenever we do these trainings, somebody always says, we need to be screening more for trauma. And we always say the same thing. Yes, you definitely should. That's a great idea. And you will still miss some. Even if you catch more of it, you'll still miss some because of all those things I said. And that's only big T trauma. Now, what happens when we add little t trauma? There are multiple instruments out there, surveys and inventories that can try to identify events that may have been traumatizing in someone's life for big T trauma. I've never yet seen an instrument that measures how many times a day someone feels misunderstood or devalued or disempowered. Never. Maybe somebody will invent one someday. That would be great. But even if you catch more of the big T trauma, you will miss some of it, and there's no way to identify in that clinical way little t traumas in the same way. So you treat everyone as if. You treat every individual you are working with as if they have trauma, whether it's known to us or not, and they need to feel safe, connected, and in control before we ask anything else, right? Before we ask for any thinking or trying a new skill or problem solving or using their words or whatever stuff you're working on with them to do, they need to feel safe, connected, and in control. And that way, you will catch the folks that you may not ever find out about in terms of their trauma history. Now, the other good thing about universal precautions like the bloodborne pathogen is that it doesn't hurt anybody. So if I don't have, hepatitis or whatever, and you put gloves on, does that hurt me? No, doesn't have any problem for me at all. So let's go back to your room. Okay, everybody look around your room for a second. You've got 100 people in there. Somewhere in there are 10 people, 10 lucky golden ticket winners who have no history of significant levels of big T or little t trauma. But you're going to make sure they feel safe, connected, and in control anyway. Does that hurt them? No. Who doesn't want to feel safe, connected, and in control? I've never yet done this training and had someone raise their hand and say, no, I preferred terrified and isolated and powerless. Where do I sign up for that plan? No one does that. So just like the other kind of universal precautions, doing this with everyone catches the people that you won't otherwise know about, and it doesn't harm anybody who happens to not need it so much. So there you go, universal precautions. And not only do you do this as a universal precaution with every individual that you guys serve, you also do it with family members of those folks that you're working with. You do that with your coworkers and your colleagues and the people you supervise. The CEO does that with the leadership team. The van driver does that with the supervisor, everybody. This works best when an organization does it all the way through the organization, up and down the levels, as well as all the way out to all of the individuals that are served. So it goes in both directions. The reason for that is that if you guys are like, I feel safe to say almost every place we've worked, you hire humans. And you guys all yourselves are humans. And that means that there are times when you need to feel safe, connected, and in control, with or without a significant trauma history. So this is something that Kevin will be working with you guys more about on his side of things, which is the organization. How do we incorporate TRC so that it's a part of what you do in all your interactions with all of the individuals you serve? And how do you guys do this with each other as well? And that's what makes you a TRC organization, right? So it's relationally based, it's universally applied, and it's organization-wide. Okay. Now, I've talked about some of this stuff. Okay, I will say this very quickly, and it's sort of a callback to what I talked about earlier this morning. Bruce Perry, and any of you who have any kind of childhood experience may have heard his name. He's sort of the Bessel van der Kolk of childhood trauma, likes to say that the state becomes a trait. And what that means is wherever our brain spends a lot of time in, can start to become how we look to people all the time. So if you are introduced to me, let's say you're my new staff person, and you're told that I'm oppositional, that I'm withdrawn, that I'm angry, that I'm, this is my personal favorite, manipulative. And that's not to say that I can't be a giant pain, but what you may actually be hearing is my brain is constantly struggling to survive. And I am constantly in one of those survival states, so much so that people think that's who I am all the time. Maybe I think that's who I am all the time. And really what you're seeing is a habitual brain state. Okay, got more on this, but I just want to keep going. Okay, I have to talk about this. So these are the things that are diagnoses that are common misdiagnoses of trauma. Okay, it doesn't have schizophrenia on there, and it should be. So this is not to say that someone who has these diagnoses doesn't actually have that diagnosis. It just means that understand that in the general population, not just for people with disabilities, it is not uncommon for trauma to be misdiagnosed as something else. We used to say in the therapy world that the average person with PTSD would have 4 incorrect diagnoses before they got the correct one of trauma. Now, it's also important to say that you can have more than one thing going on in your life. So someone could have, let's say, bipolar disorder and PTSD. So they can be concurrent. But it helps to remember that trauma can be sort of like an octopus, okay? Depending on which, I don't know if it's an arm or a leg that you've got a hold of at any given moment, when someone is in that red zone, they can look hyperactive. They can look like they're having a mood swing. They can be very oppositional, right? They can look depressed if they're in that shutdown state. They can move between them, and that can look to some people like rapid cycling bipolar disorder. If someone is screaming about something and you can't see anything there and you have no idea why they're screaming, they can look schizophrenic, like they're having a hallucination. So it's understandable, and I have a lot of patience and compassion for how long it takes to figure out what might actually be going on. But I will say, if you are working with someone who has one of these diagnoses, just know that they are sort of the usual suspects for undiagnosed trauma. So it might be worth taking another look, spending time with that individual, really gathering information from staff, from family, working with a physician or a psychiatrist or psychologist who's very, very trauma competent, because trauma can kind of mask itself in these other ways, okay? All right, so much stuff to tell you, so little time. We may come back to this. I do have to talk about this. You can imagine what you would be willing to do to feel safe, right? And if that meant punching someone or running out the door, as we talked about before, if you had no other way to do it, you would do those things to try to get safe, to feel safe in your gut, in your bones. And that would also probably include lying. Not to mention, many of our individuals, if they are new to your services and your support, they may have been in environments where lying was the smart move. If they grew up in institutional settings, or they were in a family with a lot of mental health issues, whatever it is, lying is how they survived. So when someone is lying to us, it's because they didn't think they were going to get what they wanted by telling the truth. That can be very difficult to deal with. I started out my professional life as an hourly part-time staff worker, right? So I know what that feels like, and it sucks. But when we punish the lie, okay, you find out that I told you that my previous staff person said I could have an extra pudding, so you gave me an extra pudding, and then later you found out that they didn't say that and I was lying to you. It's easy to get mad at me about the lying, right? What I suggest to you, and if any of you are parents of teenagers, you know what I'm about to say. When we punish someone for lying, what we're really saying to them is lie better next time so you don't get caught. If an individual lies to me, what I want to know is, why did they not feel comfortable asking for what they wanted directly? Now, it doesn't mean that just give everybody everything they want all the time. It does mean my job is to make it safer for you to tell the truth than it is to lie. And that takes a long, 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 long time. And even if you guys do a wonderful job with that, if I'm the individual and I have spent a long time in environments that taught me to lie, when I'm under stress, I will probably go back to that old behavior. And at that moment, instead of going, Lara's regressing, find out what new stressor is making me afraid and sending me back to old strategies. Okay. So as tempting as it is, I believe we should not punish people for lying. Punishment in general is not a great way to teach people stuff across the board, but specifically when we're talking about trauma, lying is the business of the day, right? Many, many of our individuals have learned to lie, and we have to figure out how to make it safer for them not to, rather than punish it. Okay, so let's see, we will take our break at about 1:15, I think. So let's go on a little bit more here. Basically, the rest of our time is going to be spent talking about how do we put ourselves in a position so that we can respond to the individual that we are dealing with when they are in one of those altered states. They're in that red zone or that blue zone. And I know that a lot of times people are waiting for me to give the magic formula. Just say this, and then they'll, do what you want them to do. And to that, I would just say, and I mean this from my heart, if I knew how to do this, we would, and I speak for Kevin as well, charge you guys so much more money than we do. There is no magic spell, right? What I do know is that I don't know your individuals. You do. Given enough time and patience and careful attention, you will learn what it looks like when they don't feel safe, when they don't feel in control. You will learn what helps that person feel safe. And as we've already talked about, it's different for everyone. But if you continue with that mindset of, I need Laura to feel safe, connected, and in control before I ask her to do anything else, whether she's agitated or just day to day, that has to come first, bottom up. Her brain has to be answering the question, am I safe? Yes. No snakes in here. I'm okay. Before anything else happens. And especially if I'm in that red zone or that blue zone, to get me back, to get me regulated. Regulated just means all the parts of the brain are talking to each other and working together in sync. A dysregulated brain is like a car where the brakes have been cut and there's a jet engine instead of the regular engine, and the steering wheel doesn't work. That's the car you're driving when someone is dysregulated. You want them regulated again. That has to happen before anything else. Now, in order for us to do that, we kind of have to feel safe, connected, and in control ourselves, at least to a point. All right. Now think about what I like to call magic staff people. Who are magic staff people? Many of you guys in the room are a magic staff person, or you were a magic staff person, and that's how you decided to have a career in this field, and you've gone on to do whatever it is you do now. What is a magic staff person? Well, you know who they are. They are the people when, if you're, let's say, a supervisor on call, and you look on the calendar for Saturday night and this staff person is working, you go, oh, good, right? When they come on their shift, everybody else goes, oh, good. Why? Not because bad things never happen, right? Bad things can still happen. And not because they have any actual magic powers or spells, but because there's an energy they bring that just seems to lower the temperature in the room, right? Maybe it's the one person who can connect to Kevin and get him to take a shower or, get dressed for work or whatever it is when everybody else kind of struggles. Kevin feels safe with that person. Kevin feels connected to that person. It's the person who is not going to get into a power struggle and escalate what's happening, right? They are going to calm what's happening. Now, how do they do that? Again, it's not because they have some magical, spell that they say. It's because largely their energy is calm, right? They walk in chill. They don't escalate along with the situation or along with the other people involved or the individual themselves. They stay grounded and chill. And that helps. Sometimes it takes longer than other times, but when your energy is calm, other people will start to come down to match it. We tend to instinctively sync up with the energy of the person we're talking to or dealing with. And I believe that the more individuals don't have other forms of communicating, if they have limited language or no language, even more so that we kind of communicate on that brain level. There may even be pheromones attached to it, but the simplest way I can describe it is think about a crying baby. If you pick up a crying baby and you reason with it, baby, I don't think you understand. I have to get up for work in the morning. You need to go to sleep. The baby doesn't go, oh, thank you for explaining that. I will just head right off to bed. Babies don't care about your schedule. So if you pick up a crying baby and you're tense and you're angry or you're exhausted and you're on your last nerve, it takes longer for that baby to calm down in your arms. And that's why hopefully most of us grew up in situations where there was another person, another parent or a grandmother or that other caring human being who could say, I've got this, why don't you go rest? And they are calm and they are relaxed. How do we instinctively talk to a crying baby? We go, oh, baby, that's okay. We lower our voice, we soften our voice. We don't, yell at them or give them a PowerPoint presentation. We may hold them close so they can feel our heart, they can smell our skin. There's all this stuff. There's a lot of really interesting brain science. And their brains kind of regulate with ours, all right? If this were a longer conversation, we would talk about attachment theory and attachment styles. For hopefully most of us, we had enough experiences of that when we were newborns and infants that our brains kind of know how to do that for ourselves now as adults, right? We can sort of soothe ourselves and calm ourselves. Many of the folks you work with did not have that. So again, that's another layer that we won't be getting into, but when you don't have that, your brain just doesn't have the wiring in place. It doesn't know how to do that. So all of this is to say, you as the staff person may be that external calming energy that their brain will gradually get to sync up with. It doesn't matter what you say so much at this point. It doesn't matter how you explain the reward system or what, that stuff can come later. In those moments of stress, when someone is dysregulated, it's your calming, gentle, loving presence. What you say doesn't really even matter that much. You could probably do this with someone who doesn't even speak English, right? And I especially see this. I talked with somebody, a nurse once, who worked with people with profound support needs. Many of them were in bed all the time. They had intense medical and neurological issues. They would be tube fed or whatever it was. And she said, as a nurse, she grew to understand that they could feel her presence. She could see it in, I don't know, the way their muscles contracted or how they were when she approached their bed and would talk to them. And she said, she believed, without a doubt, that those folks could feel the difference between someone who spoke to them gently and spent time at their bedside and touched them gently versus people that were not caring, right? And I'm not even talking about abusive. I just mean didn't have that gentleness. We human beings can sense that on a very, very deep level. And many of your individuals, also because they may have had to survive by reading the moods of others, when was this adult in my world safe and when did I have to get away from them, that kind of thing. Many of the folks you work with know how you feel before you do. I know this, you know this. They can feel it before you. And so if you are activated, if you are in that fight, flight, freeze, fawn, red zone, or you are numb and checked out and disconnected, they don't have anything to work with you to come back into range. You have to get into range first, and then they have something they can sync up with. Does that make sense? So it's not so much about what you're saying or what you're doing as much as it is how you are in that moment. All of this is to say, we start with working with ourselves, not with them. It's not about fixing them. It's not about changing them. I do believe, and we'll wrap up with this a little bit later, I believe that having lots of these kinds of interactions gives folks' brains an opportunity to heal, but we're not in this to fix that. We are doing this training and this set of skills that we're going to go through to change where we are, and that gives them the best chance to get their brain back online, to turn the alarm system off, and now you can work with them in whatever way you typically work with them, okay? So when I say it has to start with you, again, I'm not saying it because it sounds good. I'm saying it because it's neurologically correct. So that is why I created the CALMER skills. Now the CALMER skills, kind of because it fit the word that I chose, which was fun. But some of the steps in this model connect to some of the work done by lots of other people around mindfulness, Daniel Siegel in particular. So if any of you are familiar with Daniel Siegel and his COAL model, C-O-A-L, some of that was adapted and expanded for this. But there are also other sources for this as well. So first thing we're going to do is go through what these skills are, and then we're going to do a little bit of practicing, okay? So we'll probably get through some or all of them, and then we'll get to our break, which will take in about 10 to 15 minutes. All right. So the first skill is check in. That means check in with you, not with the individual, not with other people, with you. What are your sensations, feelings, and thoughts right now? Now, the order in which I said that is important, and I tried to make sure I did that same order all the way through the training. bottom up, body, brain, right? Our feelings are in our bodies. So think about language like my blood boiled or my stomach flipped over. I've got butterflies in my stomach. My heart was in my mouth, largely through that vagal nerve highway, which we would go into in more depth. But that's not what we're doing today. That's kind of the highway for emotions. And I will just say this to you guys about the vagal nerve complex. It's like a super highway, okay? And about 80% of the traffic is going from your body up to your brain. 80%. So imagine like semi trucks on a freeway. That's body up to brain. About 20% is from your brain down to your body. So that's like somebody on a messenger bike, right? So what that means is we notice what's going on in our body and we interpret that as an emotion, not the other way around usually. So if you are someone, let's say, who struggles with anxiety, you may have noticed that if you're a little bit anxious, you can sort of talk yourself through it, right? You can tell yourself, oh, it's not that big of a deal. I wasn't sharing my slides for a while. Oh no, but it's going to turn out okay. And you can, to use just an example I made up, you can kind of talk yourself through it and you can sort of feel yourself calm down a little. But if you have moderate to severe anxiety, talking yourself out of it does not work. And if you've experienced that with other people, or if you yourself suffer from that, you may feel a lot of frustration. I know nothing is happening. Why can't I stop freaking out? Well, that's a much more complicated discussion about the arousal network in the body. But I will just say that's why if someone's having like a panic attack, you can't talk yourself out of it. And when I work with my clients who have high levels of anxiety or panic attacks, we start with the body. We start with sometimes breath. For some people, that's too anxiety provoking. So we work with movements like Tai Chi or yoga or muscle relaxation. We start the body slowing down first. Once the body begins to slow, the breath begins to slow. I will do a quick breath exercise with you that may be useful. Then the message coming up, that 80%, that super highway from the body up to the brain is saying, oh, I think maybe things are okay. And the brain goes, oh, all right. But if you've got semi trucks going, oh my God, something's happening, the brain can't override that, right? So always start with what's happening in my body. And again, as I said, we'll do a little exercise about this, but how are my muscles? Are they loose? Are they tight? Is my face flushed? I am of the pale persuasion. I'm very, very pale. So that means that when I get agitated or embarrassed or angry or scared, my face turns beet red. You can see it from miles away. And I can feel that burning in my cheeks sometimes before I even recognize that I'm upset or angry or scared. What emotions am I having? Naming the emotion. I'm sad. I'm scared. I'm angry. I'm embarrassed. I'm happy. Those are the 5 basic human emotions: happiness, fear, anger, sadness or hurt, and shame or embarrassment. Some people add 1 or 2 here or there, but to me, that's the periodic table. These are the basic elements. What feeling are you having? What emotion are you having? And finally, what are your thoughts telling you? So let's go back to when I wasn't able to share my slides and I didn't realize you guys couldn't see them. Once I realized that's what was going on, my thoughts were like, oh no, that probably made it really confusing. I really want this to go well. I'm not sure if it's going well. Oh no, Those are my thoughts. So the sensations, my cheeks were burning, my feelings, I was worried and scared. And my thoughts were, oh no, I hope this is okay, whatever. That's what I'm experiencing right now. My sensations, my feelings, my thoughts. All right. The next thing, and they're so closely together that they can seem like the same moment, but they're actually a little bit separate. You have to accept whatever the answer is okay. Right? I have to, in that moment, if I'm going to use that example, that burning feeling, or I'm feeling worried, or I'm feeling scared, or whatever, the thoughts that I'm having, they are valid and okay. Now, that doesn't mean that they're true, right? As people like to say, feelings are not facts. So how I'm worried things are going may not be how things are actually going. Or I think my husband is upset with me because he's stomping around, not stomping, but he's like, I don't know, kind of grim and silent. And I assume it's because of me and something I've done. That might not be the case at all. But inside, there is a validity to, this makes me feel worried, this makes me feel sad, this makes me feel angry, this makes me feel whatever. Whatever it is okay. It also isn't okay to act on it necessarily. So I'm angry at my boss and I want to, stomp off and quit. Is that an okay feeling to have? Of course. Is that what I want to do? Maybe not. So accept does not mean go ahead and act on it or assume that if you feel it, it's actually happening. It just means whatever is happening inside you is valid and real and okay. This is hard for us, especially, and I don't mean to exclude the dudes here, but especially for women. I find that we are socialized to constantly worry about everybody else. And if we're not feeling great, if I'm feeling annoyed or resentful or scared or triggered by something someone's doing, especially someone in my care, it's easy for me to judge that. I'm not being kind enough. I'm not being compassionate enough, blah, 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 blah. Okay, fine. If I can just accept it as it is, this is how this is affecting me. This is how I'm feeling and experiencing this in this moment. It is much better neurologically than being mad at myself. That just keeps the wheel spinning, right? So check in, what am I experiencing? And accepting whatever that is. The next thing is I'm going to try to say something kind to myself or do something kind and loving rather than angry. When someone yells at you, how do you feel? You normally don't go, oh, that's so relaxing. It makes you tense. It keeps it going, right? And I find that we're often meaner to ourselves in how we talk to ourselves than we ever would be to anyone else. So I'll give you an example. I tend to have low blood sugar. That means that if I don't eat pretty regularly, my blood sugar drops and I can get kind of fuzzy or foggy or irritable. I have trouble with my coordination, stuff like that. Now I know this about myself. I've known it for years. So if I forget to eat and I notice this is what's going on, I check in with myself. I feel foggy, I feel fuzzy, I feel cranky, my coordination is off. And, oh, okay, well, that's what's happening. I have low blood sugar. I can yell at myself about it. Right? Why didn't I remember to eat? I know this is important. Blah, blah, blah. I can get really, really mad at myself. Or I can say, that's all right. Most of the time you remember, this time you forgot. And this will really blow your mind, but I can do something kind for myself, like eat something, right? It doesn't have to be a big deal. I can treat myself with some gentleness and kindness. And just like we said before with other people, even if I'm treating myself with that connection and that caring, it will start releasing dopamine and serotonin in my brain, and it will start to break down the norepinephrine and the cortisol from the stress. And that makes it easier for me to do whatever it is I need to do. When we talk about emotional self-care, we will go into much more detail about that process. But suffice it to say, checking in with what's going on with me, accepting whatever the answer is, and then trying to be a little bit nice to myself is much more effective than ignoring it or kind of white knuckling through it and being mad at myself. The doing something kind might be something I can actually do. So if I'm in the middle of a stressful meeting or shift, or there's something going on and I can step out for a minute and maybe get a breath of air, take a drink of water, that's great. Some of you work in settings where you can't do that. You're the only one on the shift, or there's something going on that you can't take that 5 minutes. That's fine. Even if you recognize what's going on, accept whatever that is, and say something nice to yourself. This is really challenging, and I'm doing a good job hanging in with it. Great. That's fine. That's enough to start turning the tide a little bit. Okay, we'll go through the next ones, and then we'll take our break and come back and break this down a little more. So, mindful. This is a word that people are using a lot in a lot of different ways right now. It's very popular, which is, basically great. But in its simplest form, mindful just means noticing what is happening and what is not. And here, we're not talking so much about the inside stuff we've been looking at, your own sensations, feelings, and thoughts. And now we're talking about shifting your focus to outside of you. What is happening around you? And more importantly, what is not happening? So I think we'll talk a little bit about mindful, and then we'll take our break and we'll come back and wrap up with the last two. But I do want to take a minute with this. If you think about situations that exploded, they were tense or there was a problem or whatever, and then it just, what contributed to that? I bet that most of the time, if not every time, someone at some point dug in and there became some rigidity or a power struggle where someone got mad. Okay, so the individual was already doing something challenging or dangerous or whatever, and then staff or a family member or somebody else, you know, I don't know, emergency room people, whoever it was, got locked in and they got angry, right? Or they got rigid. This is how this is going to go. Well, how did everything turn out? That's usually when the wheels come off the wagon, right? That's when everything blows up. And if you've ever been someone who does, like, you review incident reports or major unusual incidents or whatever it is, and you go back and you piece together how everything went down the way that it did, chances are you see that somewhere. And if you ever talk to the people, the staff or the parent, the family member, whomever, and you say, why did you do that? Why did you lose your temper? Why did you, lock down on this or whatever? They will often say, well, I was afraid that ... was going to happen, right? In other words, they were anticipating something rather than reacting to what was actually going on. I'll give you an example about this, and this is not a political commentary, it's just from my experience. There was one particular shelter where I worked where we often called the police because things were often happening. A parent showed up drunk, kids were having a fight, whatever it was. So we would call the police, and we were fortunate in that most of the police in the neighborhood where we were, the agency had been there for many years, the police knew kind of what we were and what we did, and a lot of them would come in pretty calm, right? And I learned after a while that I could tell how a situation was going to end up by how that police officer walked in the room. If they walked in slowly, if they took in information, if they were calm, if they were speaking calmly, chances were whatever it was going to get resolved and going to be basically okay. When it was the opposite, and it always seemed to be one of the two extremes, never in the middle. When it was the opposite and a police officer would come in loud and tense and barking orders and I knew at least one person was leaving in handcuffs, knew it. And that's not to critique police job performance, it's a different conversation, but it is to say that we kind of bring our energy to the situation. So to put this in an example, let's say that I'm an individual that you guys work with, and I have a habit of running. When I get agitated, when I get upset, when I get triggered, I run out the door, and it's dangerous. It's dangerous for me. It's dangerous for other people. We've worked with an agency, in fact, that recently had a really tragic loss of an individual who ran out onto a highway. So it's a big deal, right? And let's say that you know that when I start pacing and rocking and muttering under my breath, I'm kind of escalating, and this is what sometimes happens right before I take off. Might you position yourself by the door? Yeah, that's a good precaution. Might do that, right? Because that might be what happens. Would you run across the room and tackle me? No, that is way too much, right? I might run, and there might be a moment where someone has to get tackled, but this is not what's happening right now, right? That would be overreacting. Or in some cases, if a staff person's very triggered and shut down, sometimes they can go the other way and they're dissociated and they're checked out and they kind of underreact. But what I see happening more is that people overreact. So you need to ask yourself, what is happening? Laura might run, but she's not running at the moment, right? How do I respond appropriately to what's actually going on in the moment? So this is what we're going to do. We're going to take our break. It'll be a little bit longer. We'll take a 10-minute break. So we will come back at 12:56. And I'd like to ask you guys to do something in this break, okay? A little bit different than before. Do get up, move around, do whatever you normally do. But at some point, I'd like you to take a moment. You might want to step outside or just kind of get away from the crowd. Someplace quiet kind of helps with this. And do that check-in that I talked about, starting from the bottom up. What am I sensing in my body? What emotions am I having? What thoughts am I having right now? And we'll work with that when you come back. So I will see you guys in 10 minutes at 12:46. And again, just before I let you go, as before, if you have comments or questions or things you'd like to talk more about, let Courtney know. We'll get them into the comments section, and I will make sure to have time to check in with those things as well. So I'll see you guys in 10 minutes.